Okay, so when we talk about ortho implants, there's simply a lot of different kinds. There's pins and bolts, there's nails and rods, there's staples, there's plates, there's screws all by themselves, there's joint components. Remember, a little while ago we talked about the materials implants can be made out of. Well, here's your list of types of implants. Ultimately, each of these implants serves a very specific purpose. Pins and bolts can hold smaller bones together after a fracture or after surgical intervention and fall into the internal fixation category. External fixators also employ pins drilled into bones to stabilize a fracture, and that's an external fixation. Nails and rods are used in the medullary canal of long bones to provide that rod-like structure to the bone so that the long bone can heal around it and be solid again. Orthopedic fixation staples are large staples that can be implanted into bone to staple it back together. I personally have not gotten to experience this technique, but it does sound cool. Plates and screws are used to stabilize a fracture and provide superior and inferior support surrounding the fracture site. Screws are inserted through the plate into the bone to secure the bone to the plate. Alternatively, screws can be inserted directly into bone to bring bone to bone. I cannot tell you enough times, implants are meticulously charted. You will need to be able to communicate with your circulating nurse the manufacturer of the implant, the serial and or the lot number of the implant, the specific identifying number of the implant, where it was implanted, how many were implanted. Obviously, with a plate, there may be only one plate implanted, but depending on the fracture, that plate may have 5 screws drilled into it or 15 screws. Regardless, our charting has to be spot on. We've been revisiting units you've already covered all over this specialty, so let's keep doing it now. Pull out of your minds the information you have about sterilizers and know that implant sterilization is a big deal. Many items are prepackaged and sterilized by the manufacturer. What method of sterilization will they use to accomplish this? Plates, screws, pins, and rods are all able to be sterilized separately by the manufacturer, but most often they come in trays, which are opened onto the sterile field for the scrub to manage. Being organized is very helpful during fracture procedures. Note that implants should not be flash sterilized except in extreme circumstances, and even then they should always be accompanied by a biological indicator. Because why? This next slide covers all matters related to screw components and types, as well as the fundamental procedure for implantation. As you can see, the only thing represented in this fundamental procedure for implantation. This is huge. Know the steps of screw placement forwards, backwards, and upside down. Drill, measure, tap, screw. Drill, measure, tap, screw. Drilling encompasses the act of creating the hole for the screw to go into. Measuring allows the surgeon to determine exactly how long of a screw to implant. A too long screw often will exit out the other side of the bone and cause undue pain and tissue trauma, and too short simply isn't sufficient. We want to be like Goldilocks here and use a screw that's just right. Tapping is a step that is used when the bone is very hard and needs to have some starter grooves made for the screw to grip onto. This step is occasionally omitted in bones that are not exceptionally hard. The last step is placement of the screw, which is done with a screwdriver. These steps will be repeated as many times as it takes to get the fracture fixed and as many times as there are holes in a plate. The parts and types of screws are covered very nicely in your book beginning on page 785. I want you to know the components of the screw, the head, the shaft, the threads, the tip, as they will determine the specific screw selected from the tray by the scrub tech. Screws can have different heads, kind of like in your garage you could have Phillips and Standard. The shaft can vary in diameter, and the diameter dictates the drill bit size. The threads can be either for cortical or cancellous bone, and that dictates the amount of pull the screw has on the bone. And the tip can be self-drilling or not, which determines how easily it inserts into the bone. Ultimately, the surgeon decides what type of screw they want, but you have all the responsibility, making sure you give them what they want with the accompanying tools they need to use. The types of screws also play an important role in fracture pathology and are again selected by the surgeon. The same principles apply regardless of the type of screw you're using. Next up is the matter with plates. There's tons of plates out there. Plates are designed with different bones and fractures in mind. The industry regarding fracture treatment is gigantic. I don't expect you to know all the different types of plates, but I do expect you to know that different plates correspond to specific screws. You can't use a locking plate with non-locking screws. Remember, the serial number and ID number need to be recorded prior to the plate being implanted. Otherwise, you won't be able to see the information once it's in. Some plates are side-specific, so be aware of those scenarios so you're sure to give your surgeon exactly what they ask for. As we've briefly discussed already in previous slides, the usage of nails and rods for fractures of long bones such as the humerus, femur, and tibia. The nail or rod will insert into the medullary canal and provide internal structure allowing the fracture to heal. Many nails and rods have pre-drilled holes meant to have a screw inserted into the nail so that the nail can't migrate into the medullary canal. Wires and cables can be used to wrap around bones to bring the fragments together, and K-wires and Steinmann pins are used to affix two bones together, either to bring fractured edges together or in an attempt to fuse two bones together, like in bunion surgery. Your second to last slide shows you all the different materials used in joint replacement implants. Most joint replacements are going to be metal. Although should a patient have a metal allergy, it's possible for them to get a ceramic implant, which allows them to have the joint replaced without risking a violent allergic reaction to the new joint. The polyethylene implants are a type of plastic that is considered an insert between the two metals to negate friction. This is often referred to as the poly. The metal, or ceramic, implant articulates with the poly on either side. So femur onto poly, tibia on the underside of the poly. And the patient now has a new articulating synovial joint. On the slide in this video, you can see the femoral and tibial components are made of metal and the poly is between them, and that will be the artificial joint cartilage. We finally made it to our last slide, grafts and bone cement. Grafting material will either be autograft, allograft, or occasionally xenograft. Know the differences between the different materials. Who or what did they come from? Grafting material can come in a variety of mediums, such as injectable paste, small blocks, kind of like tiny croutons, granules, kind of like sea salt in those salt grinders, putty, very moldable like Play-Doh, and bone chips, all of which are made because there will be a situation where one is better solution than the other. It is also possible that a surgeon could require a bone graft substitute, which is manufactured and is therefore not derived from the patient, a donor, or an animal. These consist of ceramics and polymers. Finally, bone cement, which is used to secure and cement orthopedic implants in place like a total knee, total shoulder, or total hip. Bone cement is mixed by the scrub tech on the back table and is time sensitive. If mixed too early, it will begin to set up and harden before it is in place, rendering it useless, and you'll have to open new bone cement supplies and start over. Usually the scrub and the surgeon are in communication with one another to determine the right time to begin mixing. And when it's mixed properly and is ready for use, it will be soft and moldable and not sticky to the sterile gloves. There are inherent risks regarding bone cement that include occupational risks because of the vapors it releases, as well as the patient risks because it could increase toxicity and vascular events and lead to increased intramedullary pressure. The healthcare team pays close attention to the patient's vitals during this time to foresee potential issues. All right, that's it. I want you to see on this slide here what we have coming up for us. Obviously, first up is Thanksgiving break. Hooray! I would recommend you do some of your homework, though, over the break, and possibly even watch these videos one time. On Jigsaw Day, the following things will be due: your surgical procedure reports, your workbook, your Prep U, your TED Ed videos. Remember, this unit is placed at this point in the semester because it's a big one, and you probably need more time to get everything done. Don't procrastinate. All right. I'll see you soon.